So, Dr. Malcolm Bell, welcome.
Thank you very much. I was absolutely delighted to receive an invitation to come back and talk at this, I think, very important meeting. And I must say that I think that this is probably my favorite meeting to come to. I've been very fortunate to be invited back now 3 times. But I also very much look forward to visiting this wonderful country, not just because of the warmth and hospitality of the people who live here, but for this meeting, the very high academic level of discussion that we have. Also, it's an opportunity to re-engage discussion, a passionate discussion of La Liga with many of my friends here. I'll also say that this is notwithstanding the fact that we recognize that Spain is going through a very difficult period in its history, at least for this century, and it comes as a big surprise to me. But nevertheless, this is something that you have to deal with. It obviously has effects on us as well. We see the stock market going up and down every day, and something happened in Spain. But nevertheless, I think that you should all be aware that when I talk to my friends in the United States or from anywhere outside of Europe, and I ask them, what are your top 3 countries, your favorite 3 countries in Europe? And I can tell you that Spain is always in that number 1 or 2 spot. It's usually so Spain or Italy. You may not want to hear that, but let me just reassure you that Spain is still a very popular country among people outside of Spain. I have a very, I think, difficult task here, but I think the way has already been paved, firstly by Dr. Krumholz's lecture last night, and also from what we just heard from Professor Kasky. I have no disclosures relevant to this presentation, and I'm going to start off with a bold statement here, that angiography with the intent to perform revascularization, and this is not just PCI, it could be bypass surgery, and it may also, we should also think about the possibility of medical treatment here, is superior to the conservative approach. And if there's one thing that you learned today, it's that statement. It is superior to the conservative approach. However, it's conditional upon our ability to risk stratify patients appropriately and to provide optimal adjunctive medical therapy. And to this extent, I'm going to be helped greatly by the next speaker who's going to talk to you about antiplatelet therapy. So I'm not going to really discuss that in my talk. And finally, are we able to decipher the guidelines? Because if we can decipher the guidelines, then we should be able to understand that. And I'll point out that I think that remains quite a challenge. So the first question is, for whom, if not for all? And I'm going to frame this discussion by presenting a case. And this is a case of a patient that I saw just a few weeks ago. He was 90 years of age, he lived in a nursing home, and he had some very mild dementia, but was otherwise fairly fit and active. He presented with some chest pain, and you can see his past medical history. He had LAD disease documented on an angiogram many years ago. He was treated medically. He has hypertension, he has diabetes, and he has a number of other conditions there. But perhaps the other one to point out is he had chronic kidney disease. And this is his ECG. And this ECG comes, this patient presented to another emergency department, maybe about 100 kilometers from Mayo Clinic. And you can see here that there's some ST elevation in AVR, and there's some profound ST segment depression in his lateral precordial leads. So he was transferred to our facility as an emergency. And in fact, they wanted to fly him by helicopter, but it was very cloudy and they couldn't do that. And in fact, as I came in to see him, I was met by the ambulance with its red lights flashing. I had to stop my car and wait for the ambulance to come into the hospital before I could. And you can see that his troponin T measurements are clearly abnormal and significant. He had a creatinine of 2.1 with a GRACE score of 155. So what should we do with this 90-year-old who's had chest pain, who's now pain-free, but clearly is having a non-STEMI? So, the invasive or the conservative strategy. Remember, this patient was sent to us as an emergency. So we have the benefit of looking at multiple randomized controlled trials, multiple meta-analyses, not all of which come to the same conclusion, and this is a problem with meta-analyses in all areas of cardiology. And there have been multiple guideline updates dating back 10, 15 years. We need to keep in mind that cardiology practice has changed. We've seen the introduction of thienopyridines with clopidogrel, more recently now with ticagrelor. There's been an up and down use of 2B3 inhibitors, variable use of statins. We think that this should be standard of care now, but it wasn't always the standard of care. And there's been a variable use of stents and now more drug-eluting stents. So we're puzzled by this. And whenever we're thinking about this on our ward rounds, I don't know about you, but do we think about worshiping at the temple of the guidelines every day? This should provide our answers to help us with the care of our patients. So here are the guidelines. Here are the US guidelines. And I don't expect you to read them all, but I would like you to just look at the highlighted things that I've put here. This is a class 1. This is from last year. And that an invasive strategy is indicated in initially stabilized, unstable, non-STEMI patients have an elevated risk of clinical events, but it refers you back to the 2007 guidelines, so you've got to go back and find that. It refers you to 2 sections in there, which are about 3 or 4 pages long, and you have to look for another table in there to find out who these patients are. This is not simple help for us. This is not something that's readily available. So at Class 2A, it's reasonable to choose an early invasive strategy over a delayed invasive strategy for initially stabilized high-risk patients with unstable and non-STEMI. Let's keep going. Class 2B, in initially stabilized patients, an initially conservative may be considered the treatment strategy, who have an estimated risk of clinical events, elevated clinical events, including those who are troponin positive, and considering physician and patient preference. Does anyone understand these? I mean, when you look at this either slowly or quickly, you wonder whether you just read the same thing as a Class 1, a Class 2A, Class 2B. And as I've heard Dr. Gersh quote before, if you're not already confused by this, then you have not been paying attention. I don't think these guidelines are very helpful at all. And I think that as we look at guidelines, particularly the American guidelines, I've become to appreciate that the European guidelines, not perfect, but often are more simple to follow. You make a decision and you clearly put the guideline there, a little easier to follow. So, I think this is what the guidelines lead us to understand or not understand, that the whole thing has become very confusing. And I have great respect for people who put guidelines together. This is a lot of work that they have to do. But we need to make them simple, and we need to sort of get through all the different levels of evidence and try and work out what is really going to be helpful for the practitioner who's seeing a patient tomorrow morning. How are they going to approach this patient? And I'm really disappointed with our guidelines at the moment. I think that they're unnecessarily complicated. And in fact, level evidence A, B, C, it reminds me of this quote of Nietzsche: there are no facts, there are only interpretations. And we all have different interpretations of the same data. Let's look at this meta-analysis. This is from Michelle O'Donoghue. This is the more recent meta-analysis, and this is looking at 30-day outcome, looking at death, MI, or rehospitalization for ACS, and this is looking at the invasive versus the conservative approach. And I think you can appreciate that for everyone, and importantly, women. This question has come up before, but a woman who clearly has a non-ST elevation ACS benefits from the invasive approach. We've already heard an elegant discussion of risk stratification and some of the challenges in front of us. And there are many risk scores that we use. The one that's perhaps favored more, particularly in the guidelines, is the GRACE score. And we can see here looking at all-cause mortality. This is not reinfarction or reintervention. This is mortality. This is a hard endpoint. And we can see here as the GRACE score increases, the mortality increases substantially. But it's interesting, you've probably heard of the GRACE score of 140. That sort of determines who's high risk and who's not high risk. And frankly, I just don't believe that. I just don't think it's as simple as that. And if we go down to a grace score of 90, and we can see that if you're on the left side of a grace score of 90, your mortality is less than 3%. Above 90 is more than 3%. I think that's a group of patients that we can't ignore. We can't start cutting off at 140. Just look at this curve. So again, I think we've perhaps unnecessarily complicated things in our attempt to simplify things. High risk. These are the high-risk characteristics. These are similar among the European as well as the American guidelines, and they all make perfect sense for anyone who's been looking after ACS patients during their career. And all of these would point us to recommending an invasive strategy over a conservative strategy in a patient presenting with ACS. Furthermore, looking at risk stratification, and this was an interesting study published just a couple of years ago by Professor Fox. You can see here that this is long-term risk of cardiovascular death or MI. Now, what they did in this study is they risk stratified these patients according to a slightly different method. The details of this are not important. It was quite a simple method, though, but looking at the high-risk patients according to their risk stratification, you can see clearly over 5 years that the invasive strategy was better than the conservative approach, but less of benefit in the patients who are of intermediate or low risk. So let's go back to our 90-year-old patient, because he's still in the emergency department waiting for us to make a decision about what to do. His grace score is 155, but you can see we have another problem here. His creatinine is not so high, but when you then calculate his GFR is low. 27 mils per minute. This is stage 4 chronic kidney disease. And I want to spend a moment or so just talking about this, because I think this is a very important group of patients that we're seeing more and more as we see these elderly patients turn up with ACS. Now, just to remind you, this is for advanced kidney disease, stage 4, stage 5, and you can see here that taking an invasive approach, just to summarize here for patients who present with ACS, STEMI and PCI, and we're not talking about STEMI here this morning, but almost 40% of these patients are dead within a year. And that's taking that invasive approach. For non-STEMI, a 50% mortality by 1 year. These are profound numbers, and I think it's something that we should keep in mind as we talk to these patients about the treatment options. So let's spend a moment talking about hemodialysis for a while. And if anyone works in a coronary care unit or a medical intensive care unit, you've seen these machines rolled into your patients from time to time. And I like to think about this, and we talk about this with our residents and our fellows and our medical students. Hemodialysis is not a nice thing to have. And it may be that some of you in the audience have members of your family who may be on dialysis, and I think that this is a big problem. This is why everyone really, we're really trying to get patients transplanted rather than put them on dialysis. And you may be aware that in the United States, the annual mortality of patients on hemodialysis for all patients is about 20 to 25% annual mortality. But for the majority of patients, particularly those who have ischemic heart disease and are elderly, their quality of life is very poor in the majority. And we just focus on the elderly. Remember, we've got a 90-year-old patient here. Extremely high mortality in patients who are on dialysis. A third, the dialysis is going to be withdrawn. They're not going to suddenly die. We're going to withdraw this expensive therapy. And interestingly, about 50%, close to 50% of these patients do not have the capacity to make a decision at end of life about withdrawing their care. This is up to the family and the doctors to do. And there are issues of end of life. We need to be thinking about palliative care, hospice care. About 60% of patients who are elderly who are on dialysis towards the end of life regret that they were ever placed on dialysis. 60%. And of those, they will say that they only did it, the majority did it, because they thought that's what their doctor wanted. And the remaining did it because they thought that's what their family wanted. but the patient themselves regretted the decision to go on to dialysis. And we see these patients who come in on dialysis and are having ACS as well. And so I think that this is a topic for another day, but I think that there's now a lot of focus, at least in the United States, and I'm honestly not sure what happens in Europe, about facilitating this patient-shared decision-making concept. So let's look at the outcome of patients who have non-STEMI and chronic kidney disease. These are probably the best data we have. This comes from the Swede heart study. But remember, in this study, patients were all under the age of 80, and 90-year-old would not be in this study. And you can see here that the invasive approach there on the left was of benefit in all groups of patients up to moderate chronic kidney disease. But once you got to advanced kidney disease, stage 4 or stage 5, it's not clear that this is of benefit. Now, these are not randomized data. There may be very important patient selection biases here. But again, this is something that we should just all become, as cardiologists, we should be cognizant of. So when should we take the invasive approach? I don't think there's any doubt that for the unstable patient with characteristics, as I've listed here, these are patients who need to have urgent angiography. This is almost akin to STEMI-style angiography. And certainly within the first hour or two, this patient should be going to the cath lab to define what their coronary anatomy is and to treat them appropriately. So I think that's a very easy group to consider. There's absolutely no role for trying to stabilize that patient other than making sure that you do the best you can before they go to the cath lab. So early versus delayed for the rest. I've just summarized the results of 3 important trials, the ABORD, the TMAX, and the ESAR-COOL study. Important studies, and you can see that the randomized groups were having early angiography as early as 70 minutes, up to about 86 hours in the delayed groups. And you can see there I've summarized the results here. Remember, this is not invasive versus conservative. This is very early invasive versus delayed invasive. And you can see here that for TMAX and ESAR-COOL, there was a benefit, although for TMAX it was only in the high-risk patients and for the secondary endpoint. A more recent meta-analysis published 2 years ago, again summarized here. I think it's very clear with the approach that we take now that there is no benefit for cooling off the patient. I think these studies show this. There was no harm, but there was absolutely no benefit in cooling off the patient. And unlike the earlier studies that we saw 10, 15 years ago, there did not appear to be any early hazard here with intervention. But again, remember, these are patients who are all going to the cath lab at some point. And again, just to re-emphasize something that I mentioned earlier, these are not necessarily patients who are going to be having PCI. There are patients who may need to have bypass surgery, or it may be appropriate to treat them medically. But the important thing is doing an angiogram to define what the problem is. In this meta-analysis, the major benefits to an early intervention was that there was less recurrent ischemia and shorter length of stay for these patients. And that is a big deal for us in the United States in getting our patients in and out of hospital very quickly. So let me show you briefly another case here. This was a patient that I saw just recently, a 60-year-old female. She'd had chest pain. It was now resolved. Her troponin was positive. It was mildly elevated. And this is her angiogram. And you can see here that maybe some small inferior Q waves, but certainly nothing in terms of ST or T wave changes. And the decision was made. She came in late in the afternoon. The decision was made to just do an angiogram the next morning. And this is what was found. She had an occluded circumflex. Now, with non-STEMI, we tend to think about vessels that are not occluded. There was an event, but there's still a patent vessel, and that's why we have time. And this is why we wonder whether we should be taking patients to the cath lab sooner. So I think this is a missed opportunity here. She, of course, had a circumflex occlusion. This is equivalent to a STEMI, and we're waiting 24 hours before we identify this and to try and treat it. So this is a challenge, I think, for all of us taking care of these patients. So the first thing you notice about your guidelines is they're a little shorter than ours. Okay? They're also in color, and that helps. But let's look at this. An invasive strategy within 72 hours. I really don't know where this 72 hours came from. I mean, I think that that is almost made up. And it's indicated in patients who have at least one high-risk characteristic, and I showed you this before, or have recurrent symptoms, and that seems reasonable. If we look at the well, maybe the second one, the urgent coronary angiography, I don't think, again, we have any concern here. These are patients who are going to go to the cath lab within 2 hours, and there shouldn't really be any debate here. But let's look at the bottom one here. An early invasive strategy, less than 24 hours, is recommended in patients with a GRACE score more than 140, and at least one primary high-risk criterion. Well, what are the primary high-risk criteria? A rise and fall in your troponin and the dynamic SDT wave changes. For my money, I think anyone who has a positive troponin is at high risk. And how is this different to this group? In fact, your positive troponin is up here as well. So already we have some conflict between this and this. And are we really sure that someone who has a GRACE score of 150 is that much different to someone who has a GRACE score of 130? We cannot really pick out who the high-risk patients are versus the very high-risk patients, or the intermediate to high-risk patients. So I have some concerns with the way this is put together. And so just in my last few slides, let's think about how we would do this. The important thing is we need to minimize the risk in the cath lab. And I think for the most part we do. Particularly with respect to ischemic events and death. As I said, we're very fortunate. Dominic is going to be giving the next talk, and I'm going to leave him to discuss the anticoagulant, antiplatelet agents. But we have to minimize bleeding, and I'm sure he's going to talk about this as well. But I think we've also seen a reduction in the use of 2B3 inhibitors when patients are adequately preloaded with dual antiplatelet therapy and taking other approaches, such as a transradial approach. And then finally, in the patients who may or may not have chronic kidney disease, but particularly those who do, minimize the risk of acute kidney injury with appropriate hydration. I don't think it's really clear what contrast agent you should use. There are some recommendations, but making sure we keep the volume of contrast down. And a useful approach to this would be to reduce the volume to less than 3 to 4 times what your creatinine clearance is. So single vessel disease, occasionally maybe medical treatment of a small vessel, but PCI with a drug-eluting stent, no head-to-head drug-eluting stent versus bare metal stent trials have been performed in this population, except that we know that many people have drug-eluting stents. This is the standard treatment, and I think this is what we would recommend. Multi-vessel disease, a little bit more difficult. Occasionally, there'll be a patient who needs to have urgent bypass surgery, but otherwise, generally, it's accepted. We'll treat the culprit lesion with PCI, and then at some point, we will be talking about multi-vessel PCI, preferably FFR-guided or bypass surgery, and using the heart team approach. So to conclude, I would say the patient who is at low risk and troponin negative, particularly if ACS seems unlikely, or patient preference, as was the case with our 90-year-old, he did not want to have an angiogram and never did. This would be a conservative approach. Everyone else, and this is where I'm going to maybe be a little, maybe a little controversial. I would say everyone else, we should be considering an invasive approach, certainly within 24 hours. The reason for this statement here is I'm not confident we can really distinguish between those high and very high-risk patients, and I think there are many patients that may miss out on the benefits of an early invasive approach. Secondly, I don't think we have anything to gain by waiting another day or two. However, this does suggest, though, that we've got to have the resources available for this, and this will have implications for patients who are transferred from other facilities. But I think that you need a network of care. This is going to be important. And to my knowledge, there are not, at least no published experiences with a network of care of non-STEMI patients. And this is a group that I think is in dire need of a very strategic network-based treatment of care. And of course, there are patients who may not be appropriate for this, and we should just have caution in those patients who have advanced chronic kidney disease. Thank you very much for your attention.
Thank you very much, Dr. Bell, for your beautiful presentation. Now it's time for discussion. Is there any commentary or question in the audience? Yes? Yeah.
Thanks, Malcolm. That was great. I'm interested what happened to the patient, to 90-year-old patient. And the second question is, how do you organize your assistance to these patients? Do you have a network for non-STEMI? Because the problem we have in this country is that what you suggested, doing angiograms to all these patients within 24 hours, it's almost impossible because there are not networks, and I don't know whether we'll have them in the future. So probably 72 hours is taking into account all these problems besides the weekends. Probably Hector can tell us a little bit about that because he was involved in the guidelines.
So Magda, the second part of your question was what do we do with these patients? So the first question, so our 90-year-old, he said he did not want to have anything invasive. We talked to him about this. He said that his advanced directives were very clear that he did not want to have any resuscitation. If he were to die, he accepted that. We talked to him about the risks of acute kidney failure, and he said absolutely he wouldn't want to face that risk, and he would not want to be faced with the decision of dialysis. And despite so we did not do an angiogram. He went to the coronary care unit, but unfortunately he deteriorated. He had a normal ejection fraction when he first came in. By the time he left the hospital, his ejection fraction was about 20 to 25%. I suspect that he probably had left main or LAD disease, three-vessel disease, based on that angiogram. But he was treated medically, not conservatively, aggressive medical treatment. And despite the fact that there were a couple of other periods where he deteriorated and some other people looked after him, he never changed his mind. He said, just do the best you can and I'll accept this. We got our palliative care service involved, and I think this is something that we're doing more and more today. And he went to hospice, still on medical treatment, and this was just a few weeks ago. I don't know if he's still alive or not. I haven't seen him in follow-up. In fact, don't have any plans to see him in follow-up. But he made that decision himself. So the second question, what do we do in the very high-risk patients, and particularly those who are very unstable, as in that middle group, we take them directly to the cath lab, just like a STEMI. And these are people who are having malignant arrhythmias and severe heart failure. Everyone else, if they're considered to be high risk, go to the coronary care unit. And the remainder will go to our cardiology floors where they have a cardiac monitor. The problem is, though, we sometimes, I think in reality, we still cannot differentiate between those who are high risk and those who are not so high risk. So occasionally we have patients who are very high risk who are not sent to the intensive care, and they become very unstable in these other units. And other times we're looking after very low risk patients in the CCU. So I think we have still a lot to learn there. In terms of a network of care, we're actually just in the process of developing a protocol for this, and maybe in the future we could talk about our experience with this, and I'll talk about our STEMI experience tomorrow. But I think this is going to be very important. But in Spain, I mean, obviously I don't work here, but you may have many cardiologists who are looking after these patients in smaller hospitals. Should they look after them for 72 hours or more and then refer them later for an angiogram? Based on the data, I would say no, but obviously it depends on local resources, but I think it's a challenge for everyone, and I think we should re-look at this, look at our approach, and I would suggest that we need to start getting more aggressive about these patients.
Dr. Kasky.
Malcolm, thank you very much for that talk. I think, it was great, and also you touch upon a very important issue, which is a recurrent issue. We saw that in the inaugural lecture yesterday, and we see this at every big meeting we go to. I mean, the guidelines are becoming so complex and sometimes detached from reality. So what I'm going to ask you is a bit more philosophical than practical, but it's got a practical angle, because I think we all clinicians are quite worried as to what to do when confronted with this complexity. I think the European guidelines tried to simplify that, but in doing so, they miss so many things that still not very reliable. So do we need to write guidelines to the guidelines so we can understand the guidelines? So what do the sort of practitioners do when confronted with this complexity?
Well, again, I think we could have a whole morning to discuss this, but I think that, in fact, I just talked to some very high-level people who are actually involved with the very top in terms of guidelines about this just recently. And I think the American College of Cardiology recognizes that this is a problem. But again, I'll just make the caveat, I have great respect for the people doing this, but I think we feel as though we've got to cover every possible scenario. And people are scared to make a recommendation because the evidence maybe come from one trial. I think that it's better than having no guidelines, but I think that we've got carried away. There was a publication 3 years ago that looked at this, and in 2009, for cardiology alone, there were over 8,000 separate recommendations in the guidelines. So if you just count up all those I gave, and then add up for atrial fibrillation, bypass surgery, heart failure, it's over 8,000. That was in 2009. The worrying thing is that less than half of them are level evidence A. I mean, significantly less than half. So I think we have a problem here. So I think we do need to stand back and think about what do our practitioners really need on a day-to-day basis. They need simple answers, and for the most part, you're going to capture most patients. And at the risk of being controversial here, I don't know if anyone read the recent guidelines came from ACC, and it was on the guidelines for sexual activity. Anyone read those? Well, maybe I was the only one who read the guidelines for sexual activity. And I thought that this was absolutely ridiculous. Now, I honestly don't remember, it certainly wasn't a 50-50 distribution of men and women on the guidelines committee, and there might have been one woman, I'm not sure. So this is written primarily by men. The only interesting thing was what happens to hemodynamic responses during sexual activity. I mean, people have studied that. But then they made a whole lot of recommendations. I mean, you should read it and then ask yourself, was this really meaningfully helpful to our group of cardiologists? It was really extraordinary. So, yes, I think we do need to step back and think about, just how do we do these guidelines? They serve an important purpose, but they've got to be more honed in and focused.
Dr. Guess has a question. This is the last question.
Well, it's interesting. Some people obviously need guidelines, Malcolm, so I'm glad you did read those on sexual activity. I think you have to remember that a guideline, it said a camel was an animal designed by a guideline committee, that only a committee could come up with something that looked like a camel. But your point is very well made. I've been involved recently in 2 sets of guidelines. I chaired the ACC-AHA guidelines on hypertrophic cardiomyopathy. There, the discussion was very contentious, but it revolved around issues of great passion, like septal ablation versus septal myectomy. What was interesting, the guidelines were relatively simple because there's no trials in the field of hypertrophic cardiomyopathy. And so virtually everything, it's like the valve disease guidelines, level of evidence C. But that was an interesting experience. Right now, I'm working on the ESC chronic stable angina guidelines, and I do think that the ESC does a better job of simplifying guidelines than we do. The problem that the ESC faces is the diversity of the European economic community. So, we design a guideline for North America for better or for worse. But here you're dealing with countries with very disparate health systems. And I think that the danger is that you try and design something that suits everybody, and in the end it'll make everybody unhappy. And I think this is what happened with the first AFib guidelines. You just can't, we have to find that sort of middle road and say, if you can do it, you can do it, and if you don't have the facilities, you don't have the facilities.
Okay, thank you very much.